Africa where it's been endemic or hyper-endemic. It's primarily a disease of children. And so if we go back here about 15 years ago in the late 90s or early 2000, that time period here at Macha, we were admitting around 1,400 children per year with malaria. So those are the more complicated ones. Those are the ones who are admitted. We treat most of them as outpatients. And of those ones being admitted, we were having mortality rates as high as 100, 120 of those children. And then all that's compressed into about 6 months of the year. And in the early 90s, started doing research on these drugs called artemisinin, which was a whole new class of drug for malaria. And so we knew that if we could get to a point where those new drugs were available, we thought it could make a difference. So as the government approved those drugs in 2003, we started using them here. But not only using them at the hospital, we went out into all the villages, testing people to see if they had malaria and treating them. And that's when we started seeing a dramatic change. So by the year 2008, we were down to only about 50 or 60 admissions. So it went down about 97, 98%, and down to only 1 or 2 deaths. We realized that if you wait for someone to come to the hospital with malaria, whether it's uncomplicated or severe, it's really too late to treat them. And we realized that they were what you would call the tip of the iceberg. Here we call it the ears of the hippopotamus. You see, we don't have icebergs here. So the ears of the hippo is just a small part that you see, but the real hippo is underwater. What we realized is that in this community, if you went out to a village and tested everyone, most of the people who felt well, more than 40 or 50% of them actually had malaria in their body. And there's some old studies that were done somewhere else that showed after you have about 12 attacks of malaria, you develop enough immunity that you really can tolerate the parasites. They just stay in your body, you don't really feel sick from them. But yet you're a local source, so the mosquito will bite you and bites the child and transmits malaria to the child. We treat the child, but we never treat the source. Starting in 2004 up 2005, 2006, we started going out to look for these people who are asymptomatic. We call that asymptomatic malaria carriers. And we started a program of treating them all with artemisinin combination therapy, the new drug available. So that's an example of where we learned about new drugs, we studied them in proper ways. Once we proved they were safe, we then actually put them to work for us. And that's what we think helped make a difference. Together with that was community organization, community changing knowledge. If you would have gone back in 1990 and asked people what caused malaria, they would tell you it's caused by eating sugar cane and eating green maize, because that's what they believed traditionally. Once they understood it's caused by mosquitoes transmitting it, they would agree to have bed nets and use bed nets. So a lot of community education. And then along with that, other programs, bed net distribution, treating mothers who are pregnant, prophylactically. In many parts of the world, they also spray inside houses. We haven't done that in the Macha area, but we used everything we could to try to get malaria under control. We have teams going out nearly every day, screening people in the village. We're doing a lot of what we call active case detection. So if there's one case, we go out to that person's home and we test everyone within 250 meters of where that person lives, looking for other cases that might have contributed to that person. So our assumption is if you come into the hospital with malaria, you got it from somewhere, right? Yes, you got it from a mosquito, but a mosquito only flies about 1 kilometer. So unless you traveled to somewhere else, it means someone near you must have had malaria and the mosquito bit them and then bit you. So that's why we do active case detection, trying to find all those last few cases that might be there. First of all, make sure the community buys in, that understands it and believes it. And secondly, we help them realize the value of actually doing it. And we reinforce that by going back over and over again. We have both longitudinal and cross-sectional cohorts that we study here of people. And so we're visiting constantly in the villages, reinforcing that. and if we find a positive case, explaining that. And we have a very good effort here in our team, people who've grown up and lived in this area and live in the local villages, who realize that you can make a difference. In 2003, we joined up with Johns Hopkins School of Public Health as their place where they would do malaria research. And that brought in money, which is needed to expand. And that helped build this research campus and build our very high-tech labs. And then we expanded from that onwards with other grants to where we are today. So now we're an organization of about 65 full-time employees. Of those 65, I always proudly say only 3 of us are non-Zambians. So it's primarily Zambians. I think that for sustainability, it needs to be a local entity. It's a Zambian registered entity. And although we have partners all over the world, including Erasmus University, it's a Zambian entity. And my goal is to see it sustainable, to continue doing research not only on malaria, but also on other diseases like HIV, TB, whatever is there. I refused for many years to use the E word, whether eliminate or even eradicate. In the last few years, I've agreed to use the word eliminate, in the sense of eliminating transmission. If you look at our data, we brought it down by 98%, but that was 10 years ago. It's still not 0. So I would argue that actually eliminating malaria transmission might be harder than even controlling it. And that's not even getting to eradicate. So a long answer to your question is, I would like in my lifetime to see no malaria at Macha. That's been my dream, to prove you could get rid of malaria in a rural part of Africa. Because if you go back to the 1950s, they said it was impossible. It's not even worth trying. We had malaria in America, we had malaria in much part of the world. They did get rid of it there, but they never even tried Africa because they said, it's not even worth trying, it's impossible. What was in my heart was to prove it was possible, and then yet some younger people take it and spread it out to the rest of the African continent. But eradicate, we can't eradicate this disease. We should be able to eliminate it in certain areas. I think it's reproducible in other parts of rural Africa, but you have to have people willing to do it, not just sit and talk about it. And that is a big problem in my mind. I find a lot of people like to talk, but when you actually tell them you have to go out in the hot sun and go actually tromp through the ground and find these people and test them, they don't want to do that. But in summary, we've seen malaria going from the #1 cause of admission to the pediatric ward, the #1 cause of death, the #1 cause of admission in the adult wards. Even when there's HIV, malaria is #1. We've seen it go to now way, way down the list, to the point where we hardly see any cases anymore. There's a lot less children dying now than there used to be.